Okay. Well, good afternoon. We're happy to have you all here in our panel, building a culture of care and the urgent need to support health workers' well-being and resiliency. We believe that is a quite timely conversation to have. Today we have an impressive set of panelists with us. We have Dr. Leah Tadesse will join us in the panel. She's coming from another meeting that may explain also that people are still arriving. Dr. Tadesse has been the Minister of Health of the Federal Democratic Republic of Ethiopia since March 2020. Prior to her appointment, she was the State Minister of Health, and in that position, she led the national health programs that were part of the health sector transformation strategy. She is an OB-GYN by training, and she has more than 20 years of experience and as a clinician, a healthcare leader, and also she has worked in academia in the US as well, and she's also a leader in hospital and program management. So she clearly knows her craft very, very well. Her passion is strengthening and reforming health systems. It's an interesting passion, and she has received a wide recognition for her advocacy in gender equity. We also have with us Professor Idris Guessous, the Geneva University Hospitals. Professor Guessous is the head of the division of primary care medicine at the Geneva University Hospital. This is the largest primary care unit in all of Switzerland. And he has more than 120 physicians that are trained in this hospital. And he's also a teacher there at the University of Geneva. And he's one of the 7 members of the executive committee of the Swiss Society of General and Internal Medicine, and which is the largest medical society in all of Switzerland. This society has more than 8,000 members. He is also, and this is very important for our conversation today, he's also the president of the Health and Happiness Foundation. And I would say he's one of the instigators of this meeting, one way or another. He was very fundamental in all the discussions we had prior to conceiving the idea of getting together today. So we also have with us Dr. Roopa Dhatt. She's the founder and executive director of Women in Global Health. Dr. Dhatt is a passionate advocate for gender equality and particularly, of course, in global health. And she is a practicing internal medicine also in Georgetown University Hospital in Washington, D.C., and she's also faculty in this prestigious university. Dr. Dhatt is particularly committed to addressing issues of power, privilege, and intersectionality that keep many women from global health leadership roles. She's a leader herself, so she's showing how to change the world by acting in it. And we also have Traci Baird with us. She's the president and CEO of EngenderHealth in DC, in Washington, DC. She has been working in global health and public health systems for more than 30 years. It doesn't show, but it's the truth, and it's entirely true. And she has led EngenderHealth, a sexual and reproductive health and rights and gender equality organization since October 2018. EngenderHealth is an organization that works in health to support health system and strengthening, focuses on resilience and sustainability, and includes capacity building at all levels of the healthcare system. It has a complex mission in that sense, and it's also a gender transformative and inclusive program that supports clients and healthcare providers at all health systems at large. So thank you very much for joining us today. So now our conversation has, as I said, has an origin that in which Professor Guessous was kind of the culprit. I attended a conference in Dubai where Idris was presenting about a concept that was very his in the way he introduced it. But before I get there, because then it's going to ruin a bit a surprise for the audience, is that so we have seen that around COVID, during COVID times, we have seen an increase of the concepts of burnout and dissatisfaction and stress in providers. But the truth is that that situation predates COVID. So what COVID did was just to remove whatever mantle of anything that was covering something that has been simmering then for years and made it a bit uglier. So the issues of mental exhaustion, emotional and mental stress, disengagement, and loss of sense of purpose and depression has been there. Now it's perhaps a bit more pronounced. And just to get the point straight, prior to the COVID crisis, WHO said they found through a series of surveys that 50% of healthcare workers, more than 50% of healthcare workers around the globe felt underestimated and undervalued. So that's not trivial. Think of it. More than half of all providers that in one way or another WHO surveyed, they thought, my work is not that valued. And not only that, I have to work harder in order to prove my lesser value. So definitely this, and perhaps it doesn't need to be said, but I will say it anyways. So this has a serious implications for the delivery of healthcare, patient safety, and the potential increase in the extreme event of self-harm and suicide among health workers. This is particularly true in nurses. And a point here, for suicidal ideation and actually in action, men tend to have it higher than women by orders of magnitude. So in several orders of magnitude. When it comes to healthcare, this situation is slightly higher among women than on men. So it is disproportionately higher in women if you take the premise that I mentioned as the foundational element of our conversation. So these conditions that are prevalent among women may be also explained because there are additional factors that made the female healthcare worker life a bit more difficult than the male healthcare worker life. So those are, for instance, gender specific factors, and such as discrimination, double duties when caring for their families, and without too much support in the places where they live, but also not necessarily support from the community as well. Underpaid, also the possibility of not advancing their careers in the same way that their male counterparts may do. So these are additional factors that female workers in healthcare have to go through. So this is clearly a public health concern. At the end of the day, if we are not addressing this issue, we see the potential danger to healthcare system. Let me give you an additional example. So recently, a Harvard article mentioned how female doctors were leaving the profession altogether, more than their male counterparts. Now, we have been mentioning for months now how COVID affected the way healthcare is delivered and the pressure that it places on healthcare systems around the globe. And what if we see this being applied and in conditions in which their workers are actually living, the pressure is just bigger on a system that is already stressed. So you get more points on this now. At the same time, we have seen that even prior to COVID days, the recent COVID days, we're still somehow in it, is that some organizations, mainly in high-income countries or high middle-income countries, positions like the chief wellness officer have been created. It's a welcome approach, perhaps a bit timid, perhaps a bit late, but nonetheless is a sign of change, and that is important. So the idea is to build on that. So certainly addressing and preventing the issue of burnout and resilience in healthcare workers is central to any healthcare system, and strengthening or sustaining healthcare systems. It has protecting the well-being of nurses, physicians, and patients, and communities altogether should be integral and foundational and of set of elements and interventions that address the strengthening of the healthcare system in general. So that is basically what got us here, the realization of having this situation, and certainly we want to bring more attention to it, and in doing that, we will do a couple of things. One is that we will have questions for our panelists, but at the same time, we also will ask questions to the audience. So we have a large presence, both mainly today, is in our virtual participants. So we invite particularly our virtual participants to ask all the questions that they may consider relevant. But I will start with in our conversation with a perspective that, as I was saying, Dr. Idris Guessous was the culprit for. So, Idris, you mentioned something once. The first time we have the chance to exchange ideas. You mentioned how this idea of enjoyment and engagement were important elements in ensuring healthcare providers' well-being. Now it sounds like a platitude, of course, you think, but why would be something like this a critical element for resiliency? Why? Just tell us why.
Thank you, Juan. Thank you very much for the introduction. Actually, it could sound like a platitude, but we added to the discussion the fact that obviously the medical leaders, healthcare leaders might be accountable for providers' engagement, providers' happiness. And for me, this is a shift in responsibility. So obviously happiness is influenced by, let's say, external factors that we do not control. As a medical leader, I do not control external or all external factors of my colleagues. But what is clear now, even it's clear today, probably more than yesterday, that we are responsible to offer the best condition to support happiness. And this means basically assuming that you are also accountable for unhappiness at work. That means that you have to have the skills to help your colleagues to be fulfilled, and discuss together also the fact that what is surprising is we do know how to do it for patient, how to care for patient. Approaches, therapy, like the mic, or yes. But what am I doing as a medical leaders to apply that to my providers' happiness? Am I doing that kind of approach? Similarly, we are measuring parameters in medicine. We follow trends, we have action, we do early detection, screening for medicine, but I am doing the same for providers' happiness. Is it happening just at random in my division? Should I just discover someone unhappiness, or should I apply early detection, systematic test, and action plan. So basically, it was just assuming that you have at least a part responsibility of your colleague happiness, that you have to work upstream. And I would say this should lead us to, maybe it used to be a great job. Today, it's a good job. We should work really hard so that being a healthcare provider is not a job tomorrow. And I guess this was what we discussed together with a lot of pleasure, indeed, 6 months together.
Much. So this is an issue that you are treating as a subject of a study, and also you confirm, you have defined the parameters of happiness and you're tracking them. That is what you're doing with your colleagues. So it's not a fluffy conversation. You go down to metrics in a way and you're tracking that metrics to a point. I hope I got it right. So going from the perspective of healthcare service delivery and working for an academic center, which, by the way, academic centers in Switzerland are not very different from academic health centers in the US. Very, very similar ethos in many accounts. That experience could be transferable or shared with many institutions around the globe that have a similar ethos, if you would like. But going from that service delivery perspective, I would like to enter into a different field. Taking advantage of the experience of Dr. Dhatt in focusing her attention on a larger context, in the context of gender, particularly addressing the realities of healthcare providers in different settings. I would really like to approach Roopa and ask her, you recently published a report on the state of women and leadership in global health. By the way, excellent. I strongly suggest at least a thorough browsing of a document that is quite informative, and also it gives a sense of sovereign knowledge and reality for all of us. When doing that, what did you learn through preparing the report about gendered aspects on the healthcare workers' resiliency, and how do we make sure that the gender perspective is kept in sight?
Great. Thank you, Juan. And I just wanted to build on what you were saying before I go deep into the report. It is really important to recognize that those that come in to be health professionals or provide care to their communities as health providers, they do come into it with a desire to really give back. And so your point about it going from a great to a good, to a job versus a profession or to a calling. It's something that I personally can very much relate to. I came into medicine and I was inspired in my youth days exactly because there's so many wide health inequities and I wanted to be part of addressing them locally and globally. But then when it comes to practically practicing medicine, we know the growing stressors out there. And Juan, you opened up with many of those examples of great burnout happening. We are going to be releasing a report in a couple of weeks that talks about the great resignation, which is very much linked to burnout and the added burden. And there's, of course, a gender dimension, and that's what we're going to be focusing on. But I wanted to ground this report that Women in Global Health did, particularly in a reminder, the pandemic has stressed societies, but it's put an extra stress and pressure points on our health system, especially women health workers who have had added care responsibilities, not only in their households or in their communities, whether it was taking care of children, elderly, or their communities, but also added patient responsibilities at the hospital. We know that the roles when our patient-facing forward roles, nurses, midwives, community health workers, those providing primary health care. There was added burden on all of these. So women have been facing a significant amount of burden, and yet the solutions have been not put forward in a gender equitable way. And I'll go as far to say, because we are at the World Health Assembly, we have not seen the political commitment come through. Health workers, women health workers have been applauded. We've lit candles. We have, even given, sugar treats, whether it was, donuts or cookies or little croissants, maybe here in Switzerland. We have celebrated health workers, but what they really need is a transformation in the health system. So thinking about happiness and well-being is really critical in this care piece. I wanted to turn to the report that Women in Global Health just released. And I want to ground this report in the fact that Women in Global Health was started in 2015. I'm one of the 4 co-founders, and we were early career women from different backgrounds. And we found ourselves saying, when you take a look at health, health is delivered by women, but led by men. And how are we going to make sure that we transform our health systems so that health systems take care of those that are providing the healthcare services who are women, making sure that health systems are for everyone. So in 2017, we did a report with the WHO called Delivered by Women Led by Men, a Gender Equity Analysis. And that was the first time and really the landmark report with WHO. And I have to say that was the title on a WHO report. We got away with it. We were really hoping that that report would catalyze conversations in every part of the world to really start addressing the gender inequities. But what the pandemic has shown us is that the gender inequities have only worsened and exacerbated. So this is the reason that we decided to do another report after a few years looking at the state of women in leadership and do deeper analysis in countries India, Nigeria, and Kenya. There are a few key findings, and this is the summary. So if you do have time to read the report, we do recommend it. There's an executive summary as well. But what our State of Women in Leadership report is showing is we can only understand the health workers when we take a gender lens. We cannot talk about health workers by having gender blind conversations. I've been hearing this week, oh, we're gender neutral. I say, actually, when you're gender neutral, you're gender exploitative in the world of those that are advocating for gender equality. Gender blind is harmful. Just to give you an example, during the lockdown or during pandemic, many lockdown policies were put forward. And if anyone would look at those policies from a gender lens, they would know that for women, the most deadliest day in their household is Sunday. So when you put lockdown policies in a gender blind way, it meant that gender-based violence, domestic violence increased at least 30%. So that's an example where gender blind is harmful. So when we talk about health workforce in a gender blind way, it is worsening and exacerbating the issues that our health workforce are facing. 70% of the health workers are women, over 80% of primary health care and at the community levels. And I'll go a step further in saying in COVID-19, most of the patient facing forward roles were at least 90% women. Most of these women are in lower status roles, lower paid roles, and often unpaid. Frequently, they're subject to sexual harassment, and they're marginalized in decision-making, only making 25% of leadership roles. We have seen this pattern repeat itself in country after country and health system after health system. Women made an exceptional contribution to health. They have provided social cohesion and the economy in the pandemic, and yet they have not been rewarded with an equal pay or an equal say in decision-making. Our report focused that the percentage of women in health leadership has not increased in the last 5 years. Indeed, at the World Health Assembly, we do a gender count. And for those of you that have been following us, you will know that we released the gender count for this year, and it is 32%. Yet women make up 70% of the health workforce. So these numbers matter for women and for health systems. The second point I want to drive home is that the pandemic has exacerbated existing gender inequalities for all women. It's not just that these issues rose during the pandemic. They've been magnified and they've been intensified. Reports of domestic abuse have increased, as I've mentioned, and women in all sectors have had to balance professional demands while having the added care responsibilities. For women health workers, these additional burdens came at the same time they were dealing with intense and often traumatic working conditions, on top of injustices, unequal leadership, unfair pay, too little protection. I can give you examples of over 1 million health workers went on strike multiple times in India, the country that is hosting the G20, because what they wanted was to have at least some protection, some access to PPE as they were going into communities, vaccinating or testing. They wanted at least having a living wage. At that point, they were only getting $30 a month, and that is not living wage in India. And these are examples of existing gender inequalities, and they're not recognized as part of the formal health system, so they want recognition. Third, the concept of resilience can be toxic for women. And I know we're here to talk about well-being, but we cannot put the word resilience out there without really unpacking it. Setting impossible high standards and workloads for women cause exhaustion and burnout. We have seen through our research that women are expected to be social shock absorbers in a crisis. Women health workers are forced to be resilient by norms and systems that see women as caregivers by nature. Women in Global Health estimates that 6 million women work unpaid and underpaid in the core health system. This data point was cited by Administrator Powers from USAID just in her speech of the top 3 global health priorities. And the 6 million women that we are talking about, these are the women that we are now going to turn to also subsidize healthcare even further when health systems are facing economic crises. So again, I say the concept of resilience cannot be put on women without really unpacking it. We need better research on how to support all types of health workers in our health system. I've heard it too often, give it to a woman, she can handle it. Give it to a woman, she likes to volunteer. Give it to a woman, she'll find a way to care for everyone. And the reality is that women are fed up, they're done, and they shouldn't have to be putting up with this. And they are facing true trauma, true shock, and true burnout. I'll reserve some of the other points for later in the discussion, but wanted to at least share some of these grounding points as we discuss today. Thank you.
Thank you. That was quite sobering. Thank you very much, Roopa. That is an enlightening perspective. I had not thought of resiliency just the way you just presented it, to be frank. So thank you very much for that. So we have we have here the larger context of policy and reality elements from gender disparities, just as Roopa presented them. Now we're going to the tangibility of the work being done in the field and with women working in healthcare in low resource settings across different geographies and contexts and cultures. And so for that, we're going to Traci to get what is the perspective from the leader of an organization that works in the context of development cooperation. So Traci, EngenderHealth works in the public health sectors in a number of countries in Africa and South Asia. In your experience, when discussing on or defining resiliency, how is the provider's well-being considered and in this particular discussion? And what are the key pressure points in supporting the public health workforce?
Are we on? Yes, thank you. So, EngenderHealth has worked over 50 years in more than 100 countries supporting the public sector health workforce. And I have been engaged in this work for a long time, as you mentioned, and have learned from the experts, from the healthcare workers who are the experts. And so what I hope to convey is what I've learned from their expertise. I'll just be the transmission route today. I think that there are a few very practical systems areas that we can look at, that if we collectively, we the global health sector, manage them differently, we might address some of the workplace well-being issues. Of course, everything would need to be managed in context, right? So there's no one size fits all for a health system, as there is no one size fits all for a person. But I want to share thoughts in 3 areas where we can be thinking about healthcare provider scopes of practice, healthcare provider rotation systems, and safeguarding in the public health space. So in terms of scopes of practice, we, the global health field, has been talking first task shifting, then task sharing, now systems-based delivery of care. And that process has moved procedures, services, technologies down and out from centralized locations in the health system to district hospitals, say, to community health centers, to community health workers. And in fact, EngenderHealth just completed an analysis of task sharing, comparing the World Health Organization's task sharing guidance for long-acting reversible contraception and permanent methods of contraception with the actual policies and practices in a number of countries, and was looking at that gap. What is missing? What else could be done? How else could we deliver more services closer to people who need them? And that is an incredibly worthy goal. We need to consider the healthcare workforce and the healthcare worker as we approach that goal. We are asking people to do more. What's fantastic about doing more is people get new skills. Community health workers can be fantastic providers of many methods of contraception, and we should equip them with the training and resources and compensation and all the things they need to do that. We should not withhold skills from people, but we must recognize that as we transmit new knowledge and give people more authority to do more work, that we are adding to their scope of practice. And rarely do I hear health systems talk about taking something away. Mm-hmm. We're not adding people necessarily or time. We're often not adding compensation, but we're asking people to do more. And I would challenge that we could do that with healthcare workers' well-being in mind. Again, we should do more task sharing. There are gaps. We will do better at access and patient care if we get more healthcare services down to community levels and do more sharing in a team approach to healthcare provision. But healthcare workers need their humanity recognized and their limits recognized and the need for compensation recognized. So making sure that we're not doing that as if they were a robot or a tool, but that they're a human being, and we need to manage a system that is continuing to increase services and their scope. A second point I would raise is about health workforce rotations. Every country I have visited, every health facility I visited, one of the challenges that I've heard about from healthcare workers is the challenge and risk and stress of rotation. When I was in Ethiopia, maybe 3 years ago, I was talked to some nurses and midwives who were working in a hospital, but in a particular department providing a particular service. I asked them what they liked best about the service, and I asked them what they liked least about the service. Both of them said that what they liked least was knowing that they were going to have to leave it. They were going to have to rotate to another department after they had gained the skills, gained the competency, gained the confidence, and were feeling well placed for the work that they were doing. They're sitting there waiting to know that they're going to be moved. And often, healthcare workers are transferred across geography, with little control. I think it was Idris who mentioned that we can only control what we can control, right? There are some factors that healthcare managers can't control. And it may be that a direct supervisor can't control if their staff have to rotate. The system is bigger than any one manager, but that system is in our control. And while rotation leads to many benefits, I'm not sure we're considering the well-being of our healthcare workforce as we're designing it. I hope systems are, but I think systems must, to make sure that we recognize, again, these are human beings, and we're asking them to uproot, to learn something new, to transfer with or without their families, because the system needs them. So we need the system to give back to them and provide that recognition. And the last area I'll mention is around safeguarding. At EngenderHealth, we take safeguarding very seriously and include it in our training and as part of our entire duty of care. We believe that healthcare workers need safeguarding systems around them to support them. I mean, Roopa made the point that, we can't ignore gender because we can't go gender blind into a situation. We also can't go gender blind into the healthcare delivery of work, especially when it relates to issues that affect women more than men. Healthcare workers who are women are also disproportionately affected by violence in their homes and in their communities. We need to make sure that the systems are protecting healthcare workers, that we make sure that any healthcare worker who is at risk of backlash has systems to support them, that they have the mental and emotional and social support they need if they are working with, again, for example, survivors of violence. And that whole safeguarding approach is something that I believe we owe healthcare workers and needs to be built into every project and element of service delivery. So again, I think that, in terms of the scopes of practice, which need to expand to increase access, but recognizing that these are human beings that we're adding the scope to, the rotations, which again, may well serve the system, but let's remember the people we're moving around are not, chess pieces on a board. These are human beings with lives, social connections, preferences, and needs. And then the safeguarding to make sure that we're recognizing the social, emotional, and physical safety and well-being of our staff. I think these are all areas where the public health system can be doing more to be attentive to well-being of the healthcare workforce.
Well, that's over. And thank you very much. And Traci, so we get into 3 points here. One is the scope of practice. The idea is how do we manage this extension or expansion of the scope? That is one. The other is the idea of rotations, uprooting individuals that has already created some networks and some systems around that land in which they are rooted and move like pieces of on a chessboard. And the other has to do with precisely protecting the healthcare workforce, particularly women.
Yeah.
Roopa,
Yes,
you are about to say something.
I did want to build on what Traci said, and it was a part of 2 points I was going to raise, and I feel compelled now, Traci, that you said safeguarding, to unpack this a little bit from the women in global health perspective. There's 2 points I want to really bring up. One is we need to end the default male bias that undermines women health sector. I can go onto a long talk and its own panel on default male bias in the health system, but particularly from health workers. One particular data point that we have been really advocating around is we did a survey in 2021 looking at personal protective equipment, PPE, to assess where PPE was being designed from, like what was the model being used, and how many of our women health workers were facing challenges on PPE actually fitting them and being fit for purpose. We found only 14% of women health workers had access to adequate PPE. And we collected data across accounts of medical PPE, and we found that the default male body was being used from 1950s in most countries.
Oh, wow.
Yeah. So that deserves its thoughts. And second thing I'm going to say, and then turn it back to you, Juan. And again, Traci, you've inspired me, is the sexual harassment piece. Sexual harassment continues to be a taboo subject in health systems. We often talk about taking care of victims or survivors of gender-based violence, or violence they may be facing in other forms in conflict and crisis. But our health workers, our women health workers, are facing high levels of sexual harassment and violence, especially in these times. We're seeing it from several prongs. Traci, you talked about some of the options on contraception, and that there is an upskilling happening, and that is great. But with that also, we know that it's a polarized world, and women health workers that are delivering family planning in any shape, way, or form are facing higher levels of violence and being able to do their job, not just in the United States, but all around the world. We're hearing reports from upwards of 50 to 60 countries reporting cases now that never happened. And to just close on the sexual harassment, Women in Global Health released a report in December of last year called Health 2. We based it on an anonymous platform where we collected experiences and stories from all around the world. And what we found is that while there might be policies adopted, the policies are rarely upheld. One physician was talking about how in India, she reported the case of sexual harassment because she heard the policy had passed. And instead of her rights being protected, she started facing retaliation, not only from the supervisor, but her colleagues, and eventually had to switch hospitals. And you can imagine if you're turning over, leaving place to place, what happens to your career progression. We have also heard about many health systems not offering changing rooms. So if you have to do a night shift, the changing room for men and women and all genders is one room, often not locked. Sometimes even the beds that are meant for sleeping overnight, for overnight shifts, are not segregated for men and women and other genders. So you can imagine the amount of personal risk. And these are some of the stories we have highlighted. But what we're calling for is a globally validated tool that every country and every health system can use to say, this is what sexual harassment looks like, and we're going to baseline it, we're going to measure it, and we're going to track progress on whether the policies we put in place are actually changing the culture and protecting all the women in our workforce. Thank you.
No, thank you. And well taken. Thank you very much. That is an important addition to our conversation. No doubt about it. Now, at this point, I just wanted to make a disclaimer. This particular panel has we try to make it as balanced, gender balanced as we could. So when Dr. Leah shows up, we'll have a 25% male representation in this panel. And if you include the moderator, it's only 40%. So we're pretty much checking this important box here. Now, the gender perspective is something that also male professionals in healthcare can bring. So you were about to say something, Traci.
Well, we have a question from someone online that fits well now.
So, Gustavo?
Queuing.
You can read it.
So thank you so much for asking this question, Adriana. She says, thank you for naming trauma. How does Women in Global Health see how a trauma-informed approach helping the well-being of women healthcare workers, taking a trauma-informed approach to support the well-being of women healthcare workers? Jana says, thinking in particular, but not exclusively, of the risks of vicarious trauma and compassion fatigue.
Great question. And we're approaching it by particularly, again, calling for supporting women health workers. We have an initiative called the Gender Equal Healthcare Workforce Initiative with the government of France. It has over 50 different partners, 16 governments, many of the multilaterals, such as the International Labor Organization, ILO, which is putting out a convention, ILO 190. We're calling for the ratification of that. So advocacy efforts. The ratification of ILO 190 would protect all forms of informal and formal workers from all forms of violence, harassment, and ensuring that in every country that all workers have the rights protected, because the reality is there are many countries where not just health workers, but women health workers and workers themselves don't have their rights protected from sexual harassment and violence. So that's the first part, is really making sure there are policies in place. The second part is, especially on the prevention of sexual exploitation and harassment, we are calling for survivor-centered, and we have a whole slew of recommendations in our Health 2 report. And I would recommend those that are tuning in virtually to check out the Women in Global Health website and the Health 2 tab. You can find all the recommendations, but I would say the key is that we put policies in place. We make sure those are tracked, measured as they're being implemented, and always come back to the values of having a survivor-centered approach there. Thank you.
Not to be to get you under the spot here, Idris, but regarding this particular element of the discussion, how is that conducted? What is the conversation that is happening in an academic center?
If you agree, I would just also comment on the resiliency that you mentioned, Roopa, and the fact that we fully agree that resiliency is not a strategy. And we heard that also in our institution and in our network. And basically, we have to change to find solution to basically, if there is poor leadership, and this is also starting to answer your question. When there is poor leadership, when there is gender differences, when there is lack of consideration, compassion, resiliency is not the solution. It's good for the people who had it. Sorry, there might be some fortune for them, but it's not a strategy. So for all this issue, problematic, I guess even in our institution, we should rely on a strategy and not on a skill of people to fix it by themselves. Which lead me to another point, and I guess this is this can summarize a little bit all the discussion we had, and I'm looking forward to hearing all the participant comments. But it seems that, and we discussed that together, one is it's maybe time to change the patient first narrative and to assume provider first narrative for some of us, not all, but with some responsibility, depending what you are doing, at which stage you are doing, we should clearly assume that part of the mission, part of the goal, objective is to take care of the providers, maybe less of the patients for some of us, not all again. And at the end, knowing that happy, fulfilled providers should be in the state of taking good care of patients. So it reminds me from the discussion that this is a change of narrative that we can also propose here with this first meeting.
So that has, in a very nice style, heated the conversation very much. So with that provocative statement from Professor Guessous, I would like to ask a question to the audience. So whatever the audience is. So we consider this, we have seen that there are multiple perspectives from public sector to NGOs to academic centers and the private academic centers or quasi-private institutions. So we have very different perspectives. Male, female, I mean, no matter how we work this out, we carry all our structures, mental structures, cultural structures, social structures, we carry them. So in your experience, do either nonprofit private entity and a public sector institution have in fact a different approach to managing providers' well-being? Do you think it's different depending on the economic sector where the organization is? Yes or no? Or it's complicated? And better said, do these institutions have a different way of approaching the concept of well-being and addressed differently depending on the economic conditions in which they are presented? You have experience in both low resource settings and rich countries in managing conditions. But from the audience perspective, we would like to see whether there's kind of a difference in any of these. Now, how's that reflected in case that we want to come up with a holistic approach to this crisis? We do believe there's a crisis, as a matter of fact. So, Siam?
Thank you very much. Actually, maybe to answer this question and to go back to what Professor Guessous was saying, and to look into the engagement and the purpose that all healthcare providers have. Healthcare workers are essential workers. They're essential workers everywhere, whether in the public sector, in the private sector, in low income countries and high income countries. Healthcare workers are essential workers. And so there shouldn't really be a difference in how to take care of the well-being of healthcare workers, depending on the sector or depending on the country. I think the well-being should be, like you said, provider first, in the sense that healthcare workers are coming with a lot of engagement, a lot of purpose. Usually there's a selection bias even to who goes into medicine or healthcare professions. And so what we're seeing now is kind of the shift into, because we have increased absenteeism, we have increased maybe sick leave or staff that is absent. And so it's the colleagues that are taking over. And so not only is there an increased scope of skills and things that one person is doing, but they're also having to take over what their colleague was supposed to be doing. And so it's that engagement and purpose that is going so far, and there's no limit to it because it's innate to a healthcare profession that needs to be taken into consideration when organizations, companies, or systems look into the well-being of their staff. The staff will go the extra mile every time, probably. And so who is accountable for kind of saying, no, now we're going to have to step back a little bit, whether in the public or in the private sector?
Thank you very much. So if I understood this correctly, so is the condition of the profession the one that in a way almost determines the kind of dialogue or the perception about the profession, better said, is the one that determines the conversation almost regardless the setup? It's the expectation that healthcare workers must do, act, depending on certain conditions. It is a workforce that we cannot perceive of. So it determines the conversation altogether. The health worker as a hero, sir.
Thank you very much for this opportunity. My name is Opoku Wampoma, and I'm the CEO of the biggest teaching hospital in Accra with about 8,200 staff. And so I come from Accra, Ghana, West Africa. And this is something that's quite topical now because we've seen some changes, especially after COVID. We've seen quite a lot of change. And this is a conversation that needs to be had at this time because it would determine quite a lot of things that happen in the future. But to add to the point, there's, like I said, historically, health workers, especially in low middle income countries, have been seen to be more or less like a privileged class. And so everybody talks about the patient, but there's no focus on the healthcare worker. And also, like she rightly said, there's also a certain kind of people who go into healthcare. And so, and there's also a generational thing, because in the older generations, it's more like being stoic and just, getting on with it. And it's not seen to be cool to complain, when you even have personal challenges. You're just supposed to just find a way of dealing with it. So there's no structured system of taking care of the needs of healthcare workers. And so even now, although the younger generation are beginning to complain, then there's a generation difference, because the older generation think these young guys are just wimps, they just complain at the slightest thing. But it's because we a lot of what we did was taken for granted. And so you'd see, even from basic things like conditions of service, you find that healthcare workers are trusted with enormous responsibility. But if you look at remuneration, even as an example, it is totally, I mean, it's nothing to write home about, and so you'd find that, so if you drill down, you see that there's a lot of things that have gone wrong in this area. The question now is how do we bring this into the consciousness of the decision makers, especially at the level of government. And in fact, the numbers here is one part of the story, that hardly anybody thinks that this is something to prioritize in terms of, the future. Because if we had some other meeting talking of various policies, you see the place will be full to the rafters. But this is really, really, for me, this is really, really a critical area. And post-COVID, we are seeing a mass exodus of health workers, especially from the low and middle income countries, because they are going abroad to fill gaps that have been left, because a lot of people experience burnout in the developed world. And so there are many job openings, and of course people in the third world are seeing that, well, if I'm going to suffer, I might also suffer and get a good salary at the end of the day. I mean, someone said that if I have to cry, it's better to cry in a luxurious car, than to cry in poor conditions. So it is something that I see as a huge challenge. It's one of the existential threats to some of the gains that have been made, especially in the third world, with regards to the progress we've made in healthcare systems. Because where I sit, I can see every day I'm signing letters for people to resign. I mean, and initially it was a trickle. Now it's a hemorrhage. I mean, it's a massive flow. And my worry is that it looks like the political leadership isn't really conscious of this. And by the time we become aware of it, it will be too late, and to erode all the gains that we've made in the past. I think somebody made an allusion to the fact that for the first time in decades, we've seen a reversal of the gains that we've made from vaccinations, infant mortality, and all that, maternal mortality. We've seen an erosion in the gains that have been made. And so, but I think that at the core of it is this issue of how we take care of, the healthcare workers.
Thank you
very much.
Thank you very much. So we're welcoming Dr. Leah Tadesse. It's a pleasure to have you here. As introduced initially, Dr. Leah is the Minister of Health of the Federal Democratic Republic of Ethiopia. She has been in that position since 2022. However, she has been in a leading position in the ministry as State Minister of Health, when leading the national health programs under the Health Sector Transformation Strategy. So she has vast experience in different roles in health. You tick all the boxes, so definitely we are eager to hear your voice and opinion, Dr. Leah, on the issue that we have at hand, the building a culture of care, healthcare workers being able to work in a really dignifying condition. So that said, I will ask a question for the panelists, the same question for the panelists, but I would like to ask Dr. Leah to answer first. So here we go. WHO estimates that, as we said initially, that more than 50% of the healthcare workforce feels overworked and underappreciated. So it's kind of the wrong math here. So that is something that has been found there. Obviously, we think that it has serious implications on the way healthcare is delivered and across the world. So as we prepared for this panel, we discussed the need of a human-centered approach, the people-centered approach, and not drop focus on healthcare workers by being only patient-centered. That has emerged. We have been provoked by Idris when he just came out and said it to the world, for the world to hear, and it has been already part of the conversation here. And so for us, how do we make sure that we keep a holistic view and continue to support improved patient and community health? Is that a shifting of poles? Is creating a polarity? Is what? As the leaders in healthcare and in healthcare transformation that you all are, how do you see this? Dr. Leah?
Thank you very much, and greetings everyone. My apologies for coming late from another session. And really, I'm happy to be part of this very important topic on health workforce, and also really the support that we need to provide our health workers to deliver better, but also really to value what they are providing. For us as a country, of course, a large focus the past decades has been investing on the training of healthcare workforce, given the huge shortage of workforce at the different layers. So we have been investing from training of the community healthcare workforce. For us, it's a formal training after high school at different levels. So really training them, putting them into the workforce as formally paid. It's part of the civil servants or the health workforce, up to training physicians, expanding training of physicians and different health professionals at the multidisciplinary training. And then, of course, in recent years, we have also been focusing on the quality of training in addition to the number, but the emphasis, the need to support health care workers in different ways had not gained enough attention, especially until recent years. The recent years was a big learning for us, especially with the pandemic, followed by for us as a country, we've had different conflicts which had impacted healthcare workers directly. With the pandemic, we had done different initiatives to really respond to the need for the response in terms of really training different healthcare workers in a short term and hiring them, because one other challenge has been also unemployment of a large number of workforce that we had trained, bringing them to the workforce, but also trying to see how they can be supported given the obvious overburden and burnout that they were facing. So, of course, the government was quick to approve our application of incentive for the stressful work environment that, especially in COVID centers, those who are directly serving COVID patients. So at least compensating that with some incentive, and also trying to work on some health insurance system, life insurance system for that cadre of professionals. But we had developed a national advisory group of different health professionals to advise us on the response for the ministry's task force. And one of the key inputs we got was from those who are working in the mental health and psychosocial area. They came up and said, we need to organize how to support our healthcare workers in terms of mental and psychosocial support because of what they are passing through. So we had organized volunteers to provide that. And then, of course, these are small initiatives I'm talking about, which need to become a system-wide approach now as we move forward. But conflict was another challenge. We had health workers facing two kinds of challenges within the conflict. One, they are directly impacted by the conflict as a community who's living in the conflict areas, and then not being able to provide the needed care in the settings in the conflict disruption. So it was a double burden, and sometimes they were not paid at all because of the disruptions. And as we are thinking of the rehabilitation and starting rehabilitation with improving peace situation, that was one of the key issues. We are trying to intervene with a joint effort with Social Affairs Ministry, where we had a multidisciplinary training of social workers, psychologists, mental health professionals to do both support to the community, but also to the healthcare workers in terms of really supporting them to come back to work. But I'm mentioning these are efforts, but these are not something we have as a system. These were pushed by those challenges we had, but it's so critical now to really see how can we continue it as a system, so that our aim is to provide patient-centered care, but the healthcare workers as the pillars to provide patient-centered care. How do we make them motivated? How do we make them recognized? So as part of the quality improvement work, also we are trying to see what are the small things we can do to make the working environment conducive for our health workforce. Before I finish, sorry to take time, one simple example is women. We were talking about this with Dr. Roopa yesterday. Women face also different challenges within the health workforce, and one of them is unfortunately still gender-based violence. And one of those factors that expose them to this is the way our facilities are set up. They don't recognize gender of health workers. So the resting rooms for when they are spending the night, they are the same for men and women. So they have to share the rooms, and those things may seem simple, but they expose them to different challenges. So addressing those things, which from those things that seem little, but also having a system in place where we can support is critical, but also, of course, it requires resources, coordination, and support, and as it requires investment. So I hope we'll be able to continue building on those learnings that we've had.
Thank you very much. It's an illuminating response. You're telling us, okay, we have been reactive so far. There are things that are structural. This reaction may be good, maybe teaching us something, and perhaps something is welcome here, but there's something else. So, Idris, having the response from the perspective of a large national system, and that is both a policymaker, regulator, service provider. Now, from the perspective of a leader in the academic setting, in the service delivery setting within an academic institution, how's that?
So definitely I will not answer directly your question, but I would also just answer or address our colleague in participant who asked two questions also, and then hopefully I will address your specific question. You ask about decision maker, how we can influence them. In my opinion, the waking call will be brutal, and they might react with a short-term answer, with money, budget funding, which will be pleasant, but will not lead to happiness of the healthcare worker. But in my opinion, the issue also with politics, and maybe there's a link, is politicians are rarely judged on their efficacy to fix healthcare outcome. No politician has not been re-elected because diabetes, obesity was increasing, because depression, because violence was increasing. And I guess at some point we should also elect based on the deliverable of a politician, and they should also tell us what's the plan, how they plan to reduce that amount of obesity, violence, depression, and if they fail, we change. That's also, in my opinion, what can be done. Decision maker could also change the paradigm of an academic leader that is changing the way we are funded, not only by the number of consultation act, but how happy my providers are. And at some point, if you reach what 12–14% sick leave in your team, there is a problem. And I don't get the fact that independently of your results, how you lead and take care of the provider, which is the human capital that politicians are investing in. So if you waste capital energy by making people better, not coming at work, you should not be funded as others that perform better. It's in my, and maybe, I guess, in terms of actionable levier, it might work. At least it might help. And finally, for the generation issue that you raised, this is obviously an issue. It's a reality. We don't have any generation. It's the one who is there. We are the one. They are the next one. My feeling is the challenge is really to make the shortest distance between this generation expectation, what we call job fit, the job they think they are the best at, because this is what they want. And this is maybe less what we wanted, or we were more patient. They want the job to fit what they are the best at. So we have to find the solution, the equation to reach providers' expectation and organizational needs. This is tricky, but I guess if you have that in mind, it's feasible. Did I answer your question, Juan?
You did the best to avoid it. Roopa?
So much to comment and reflect on. I have to say, I did have a reaction when you said your comment about shifting the thinking in our health systems, instead of being patient-centered to being provider-centered. I really say we must be people-centered. You know, going back, I know it was meant to be provocative. As a physician by training, and our mindset and what inspires many health workers to come into this field is the human side of it, and saving lives and being part of that. So I don't want to say I'm completely on board, but I know what you're getting at, and there's a lot to say. But I want to foremost acknowledge Minister Honorable Tadesse. Thank you for being here, because you are a member of the Gender Equal Healthcare Workforce Initiative. We're often citing examples from Ethiopia because they are not being reactive, they're being responsive, and they're approaching resilience, not necessarily from an individual, but a systems point of view. And I know that's what you've shared, but we were sharing examples from particularly Ethiopia just moments before. And I would say to address taking care of our healthcare workers, we must first of all realize it's an urgent issue. That's what the title of this session includes. And I'm not feeling the urgency in the city the way it ought to be. We are facing a 10 million health worker shortage. We know that health workers are resigning at high numbers, doesn't matter where. I practice clinically in DC. I know that the nurses I work with, they are younger and younger. And why? Because the older nurses have left, or they've shifted out of patient roles. They're still in the sector. And that's a problem, not an individual problem. It's a systems problem. Going back to your point that if you do a survey and people are taking sick leave or burnout leave, we need to really deeply look at that. This is also destabilizing health systems around the world. We have talked to numerous governments, had bilaterals this week, but also in the last year. And what we have found is as there is a great resignation taking place, we are also seeing a great migration. So many countries are having more and more nurses, midwives. We've always had physicians migrating, but we're finding that the patient-facing roles that health systems count the most on in our most challenging circumstances are losing them at a higher number, not just within their own context. Data to remind and ground ourselves, WHO releases a safeguarding list. They released one this year, and there's 5 more countries on the safeguarding list. And majority of them, 85%, I believe, right, Dr. Tadesse, are in the Africa continent. So this is not just a problem of what's happening in our local hospitals and health systems. As I talked to my colleague here from Europe, it is, I practice in Washington, D.C. We have a responsibility in high-income countries and low-middle-income countries across the world. And we must do this from a gender point of view. As I've mentioned, there's been millions of health workers striking all around the world. I think at one point we did a count on the news, and there were 100 countries facing health workers striking because they are just done. And it's time to look at it from a systems. At Women in Global Health, we say equal participation of men and women in leadership. And it's not because it's just the right thing to do. It's because we miss out on the expertise women have. We miss out on the solutions they want. So when I talk to colleagues around the world, women are saying we want safe places free from all forms of harassment and violence, not because it's a good thing to have. It's actually the reason they're leaving. They're leaving because they're getting sexually harassed. They're leaving because they're facing personal risk. We know how polarized societies are becoming, and this is not going to stop. The top thing that medical students I interviewed during the pandemic said as the public health issue of their times was mistrust. They said, that's the most important thing that we're looking for. And when we put the solutions forward, we tend to focus too much on the individual, and we must be looking at the systems. So that's where this point about mental health, I believe my, if I can call you my colleague from Ghana, you know, as someone that is graduated not too long ago, over a decade ago, it was often seen as an intergenerational issue. Oh, the young don't want to work as hard. I always challenge my colleagues and say, actually, the young work quite hard. They have more data than ever to process. We don't get any downtime, especially if you get technology in your hands. They also are facing trauma because they were the last to get vaccines. Even in the hospital I practiced in, the medical students were not counted as health workers, so they were not given the vaccines in the first round. And our residents who are the trainees see patients more than the attendings because they're the ones at bedside. We're on the last of the list, and there were many hospitals, I won't put any on the spot, but university centers where the residents and medical students in my country called out, you know, you're not vaccinating us. The group that Women in Global Health is particularly bringing attention to is the community health workers at this World Health Assembly, who are majority women, 90%. Many of them never had access to PPE. They weren't getting vaccines. They're not getting paid. They're not even part of the formal health workforce because there isn't a global definition on what a community health worker is. Right. And so I think until we start working on these systems issue, we are not going to be able to address this, but the political commitment must begin at the highest levels. And we, from our different roles, must remind our political leaders to take action now. I can't wait. Thank you.
Thank you very much. So, Traci, you have now the opportunity to balance the conversation from the perspective of development cooperation and large global NGO. How do you see that? How do you see this this balance that we're talking about?
So I want to start by reflecting on the fact that when people in my network, my community, are caring for family members that have cancer or a debilitating condition or Alzheimer's disease, for example, there are a lot of support networks to help that family caregiver. We talk about needing to care for the caregiver because if you don't take care of yourself, you can't support your loved one. What I'm hearing here today is that we need to extend that to everybody providing that kind of support, including those who are paid and trained to do so. We need to care for healthcare workers, and healthcare workers need to care for each other. There's no really we here doing it for someone. This needs to be something that is done collectively. So I want to both and this. I don't think we're served by a patient-centric system that keeps healthcare workers just being tools or automatons and just doing work for others. I'm not sure we're served by a healthcare worker provider-centric system. If we can be more human-centric, I think we would find that balance. And that would give us a model that allows us to work at a systems level, like Dr. Leah was reflecting for Ethiopia, because we have a pandemic, there may be conflict, there may be drought, there may be other emergencies, either acute or chronic, that are putting stress on the system. And if we don't center humanity, in my view, we will continue to fail humanity. I was really struck hearing about different levels of resignations in Ghana, or the, as Roopa said, healthcare workers retiring early or moving to administrative roles. If somebody working at the front desk of the Intercontinental Hotel, where many of us have passed through this week, if they start resigning, it's a great inconvenience for the guests. When healthcare workers are resigning or not joining the profession, people die. The stakes are really high here. We've got to get this right. We at least have to do better. So again, I want to both and it, recognizing that healthcare workers, in addition to the impact of being in a gender unequal world that we're working to sort, they have they carry with them their ethnicity, their religion, any physical disability, anything that is already adding to the challenges they face based on the societies they're in. They have their own healthcare problems, acute or chronic, right? So we're talking about healthcare workers as if they're all showing up healthy and enabled and trained and compensated and ready to go. And I'm not sure any of those things can be assumed to be true. The last point I'll make is, in this room before our session, there was a fantastic session on self-care, talking about if you want to meet people's needs, whether it's for family planning or HIV testing or chronic disease management, a lot of needs can be met by supporting the broad community in self-care. And I didn't make this connection until my fellow panelists were speaking, but I don't think we should keep these two topics segregated. I'm not saying we shift the responsibility to patients and say, take care of yourself. Here's the to-do list to go take care of yourself. But there's a lot of opportunity in self-care to give people greater agency, to give them the care and support that people want and need. And that might be an interesting way to think about this dynamic between patients and providers. And how can we be really working together in a systems approach to make sure that everybody's well-being stays front and center?
Thank you very much. Clearly, we have covered we have walked through a long bridge between what we have today and what we may be going to. I have time for one question from the audience for the panelists. Madam.
Hello, thank you very much. I'm Olivia Braillard. I have the pleasure to work with Idris Guessous in the Geneva University Hospital. While listening to you, I was inspired by the chronic care model, which emerged in the 90s in a response to the health system was not adequate for caring for chronic diseases, and it was made for acute diseases. And the chronic care model was created to propose a solution with different axes of work. And it was a great base to work on, and it led to patient-centeredness, to partnership with the patient, and many other conceptual frameworks that led us to our system today. And I was wondering if today was not the day to propose the human care model or the people care model, which would be easy to communicate, to raise awareness about this problem we have today, and to federate everyone around one model and maybe build something over this to find solutions that would be both on the field and both on the political field too.
Okay. So, any comments? Yeah, for instance?
Thank you very much. That's a very great proposal, and I think we need to continue discussing this on how best to approach the holistic approach of seeing the care we deliver, not just for the, as was mentioned, not just, we have been saying, of course, patient-centered, client-centered care model that we are trying to move to, be it emergency, be it chronic care, but how do we really see the healthcare workers fit into that client-centered model where they are also not just givers, but also receive the needed support they need so that they can really deliver that care we can provide. So it requires intentional investment and strategy, but really looking at it holistically is a key issue, which I agree, making it comprehensive as we move forward, rather than looking at it as silo.
Perfect. Thank you very much. So I'm going to ask now a question to the audience. So, and we will get back to this point. So after we ask the question to the audience, the panelists will have 1 minute to come up with a closing statement from their side. But the question to the audience is, in his closing remarks recently for the 5th Global Forum of Human Resources for Health, the WHO Secretary General mentioned the need to protect the healthcare workforce. That said, he did not mention specifically the well-being of the healthcare workforce as a priority. He said, based on that the discussion was going, he referred to it in different terms. I'll address them. This subject, do you think, let me put it back here. So he said, well, we should protect the healthcare workforce. My question to you is, do you think this model should be singularized and addressed accordingly? Or as a subject on its own, the well-being of the healthcare workforce? Or do you see it more included in a larger context, and for that reason will be automatically addressed when you are tackling issues like remuneration or workload? That was exactly the way it was presented. Should I clarify my question? It seems that perhaps I should clarify my question. So in the closing remarks, there was no specific mention about the elements that could be addressed, but there was a general mention that protect the healthcare workforce. And among the list of elements that were addressed systemically, but one of them was, okay, remuneration, and the other was workload. These two elements address the needs as we have discussed them. What do you think? Only one at a time.
I mean, remuneration and workloads are two elements, but it goes really beyond that. And this is what our panelists have talked about today. It's really about the real well-being of healthcare workers coming to work happy, leaving work happy, knowing that you're happy with your team, with your colleagues, working for your community, contributing for your community. So all these things go beyond just, obviously you have to value the work and give the right salary, the right remuneration, but that shouldn't be just, it should really go beyond, so that there's what Professor Guessous calls a fulfillment, like real fulfillment of healthcare workers. So
in other words, you believe this perception or this conceptualization of the problem still falls short of what it actually should be addressing.
These are the baseline necessities.
Baseline.
protecting healthcare workers in conflict zones, and this is the baseline. This is like a human right, and we have to have that remuneration, the appropriate workload. These are baseline necessities, and we need to go beyond that and look into really the fulfillment and well-being of their workers.
Thank you, Maisam, for your answer. Now, back to the panelists. Your statement. Dr. Leah. You want to comment on that?
I do, because I think that we need to be careful not to use window dressing language when we're talking about such an important issue as protecting our health and care workers. And again, I'm going to recognize the work here of Her Honorable Dr. Tadesse from Ethiopia. Protection included doing gender-based violence assessments. When I first heard Dr. Tadesse say this on a Zoom call, I said, this is exactly how you bring accountability into these commitments. Protection means counting it. And then as we were chatting the other day, if I may so kindly share, Dr. Tadesse said, we have to count to then, design the solutions and then measure the progress. And I say, if we cannot define these words of what protect really means, get concrete, we won't make progress on this agenda. And I have been advocating in global health for a few decades now. And the issue of protecting health workers is not new. And what we need to do is say, let's go away from the window dressing and let's look at what are the problems? Why are we not able to protect our health workers and the issues that we have talked about that we must learn from the lessons of the pandemic? So I'd say, challenge all of us here. Let's all go and define what protection means in our local context and what will be in the global level. And for women in global health, not enough of this is being done from a gender point of view. Thank you.
Thank you very much. Now, going back to the 1-minute sentence that we're going to ask from you, Dr. Leah, what is your closing idea for this panel?
Thank you. It actually relates to the last question. So, I mean, addressing the issue of care workers in terms of protection, what we need to do should be very holistic for healthcare workers. The development, the motivation, the protection, that design has to be holistic. Even investing in helping them have the necessary skills and the necessary environment, supplies, everything they need to provide the care, because the challenge we are facing is very different from country to countries or economy to economy. So not even having the right gadgets in place, the right skills to deliver the care is another factor that can really affect healthcare workers, which I have reflected about the conflict issue. So it should be a holistic approach of development, motivation, protection, and providing the needed skills, and particularly the new issues that are emerging that we have seen, the mental and psychosocial support. So the holistic approach from training to remuneration and everything in between should be thought about. So that's for us, a human resource development and improvement strategy is what we are looking at.
Okay. Thank you very much. Idris.
Thank you. Well, of course, it was obviously provocative. So let's reassure people. So 100% of patients are people, 100% of providers are people. So definitely it's a people approach. I guess we were talking about staff shortages, skills that may be difficult to replace. My concern is also about the next healthcare leaders, medical leaders, because if we are in shortage of staffing, what will be the next medical leaders? So if we do not identify and promote, or be sure to promote the best compassionate, strong healthcare leaders, we will not fix the problem because the situation will be worse and the teams, the colleague will be hurt and feel poor leadership. So let's be sure to promote the best-hearted medical healthcare leaders, and let's walk the talk.
Thank you very much.
Thank you.
Roopa?
Thank you for that. I'm glad to hear that message come out, Idris. We continue to campaign for equal numbers in women in health leadership because women bring perspectives and we cannot lose out on this expertise. When we ignore these, we know the consequences are not only about losing women in the health workforce, it's also about losing lives. And Traci, your message very clearly needs to resonate outside of this room into every room that is being discussed about health, because we lose lives when health workers are not supported. If leadership roles were allocated proportionally, women and men, based on equal merit, women make 70% of the health workers, and then they would be 70% of the leaders, but we are not there yet. Gender inequity in health leadership is not solely a women's issue. We did a conversation on universal health coverage and sexually reproductive health and rights, given that there's a high level political meeting happening on this, and we know the real threat to women's rights there. So we lose out on women's lives when again we're not protecting those rights. And so one of our panelists said, when you invest in a woman, you're not only investing in her, you're actually investing in men, and you're investing in all societies. So let's look at it that way. Status quo must change. All leaders in health must intentionally promote gender transformative leadership. That is what we're calling for. So not just putting women into leadership, but everyone being gender transformative and looking at it from a systems aspect. And finally, I'd say that, you know, the systems for us means looking at legal, cultural, social barriers that prevent women in health from attaining the positions in management, leadership, and governance. And we believe that the pandemic should be a place where we break from the past and we have a new social contract that is based on equality. Thank you.
Thank you. Traci?
Thank you. So I have the benefit of being able to see our chat. So I'm going to incorporate into my response the very insightful comment from Laura Garad, who commented here that healthcare workers are working in a culture of shame and are in fear of making errors, or fear of, you know, if they take time off for burnout or their own health, that they'll be called out by the hierarchy and called out for why they aren't able to serve. We need a safety culture. We need a culture where not only can you report and put up the chain in your healthcare system issues of quality assurance and bad outcomes, adverse events, but also ones where we feel safe, right? We need a safety culture where people actually feel safe going to work and feel safe if they can't go to work, knowing that they need to be well so that they can. You know, often when I talk a lot about women in leadership and gender equality and how we can have more gender equal and fair workplaces. And my response is usually, well, let's just start, take some steps. If we sit here planning for 5 years, we'd plan for 5 or 10 years before we thought we had a really good comprehensive plan, and then we're not doing it. So I like the point that we need to walk the talk. And I would say, let's just start and work on that comprehensive plan. Let's do both. Let's start with what we know. Let's start with making sure that the workplace is safe for people. Let's make sure that there are changing rooms and overnight rooms that are safe for people, that we are supporting women in leadership in all aspects of global health so that we can shift that balance. There are things we can be doing today while we're designing a bigger plan that really centers the humanity in not only the patient population, because yes, patients are human, and the healthcare workforce is human too, and shifts that and rebalances that so that everybody has a place and we are upholding rights and bringing justice to global health writ large.
Well, thank you very much. So with this, what what I think I just have to comment, first of all, thanking you, but also I would like to ask the audience to ponder on the following. This conversation today, and actually the parts of many of the other events that we were looking at and we have been tracking for some time. And again, I would like to bring all the blame on Dr. Idris when he started that conversation on happiness for providers. It was something absolutely new in that sense. Well, the idea is that the patient-centered paradigm has served us well to improve service delivery, to address important needs on this. However, what we're realizing is that we are at the moment in which that paradigm no longer works as well as it should. We need to do something else. Now, and clearly, based on what we have learned today, we cannot be just merely reactive. We have to ponder this well, and we have to be intentional and directional in this particular change. Also taking the responsibility, not just through the policies and creating the conditions and ensuring that the tools and elements to provide care and people is properly trained. I can't imagine how practicing without being trained stressful can be. So being properly equipped in every council to proceed, but also leadership being accountable to ensure that those elements that make a team, my closer team, happy, productive, engaged, fundamentally happy are there. And addressing the differences in gender are central in this conversation. We cannot ignore them. We cannot continue walking through this world thinking that we can be gender blind. It actually has a cost on us. And at the end of the day, having a response that is comprehensive, that addresses these elements, that fully understands the needs of the providers as also part of the needs of society, are an important conversation to initiate, carry, and see that there's a future after this. So thank you very much for your participation. To every one of the panelists, I would like to thank EngenderHealth and also the Hôpital Universitaire de Genève for their support here, and to Doctors Lilia and Roopa for their participation here too. And to the audience, thank you for your answers, for your questions, and for bringing this problem further in your subsequent conversations. Have a great day.